We are now live. You can unmute and start, please.
Hello. Good evening, everyone. Am I audible?
Yes, sir.
Yes, sir.
Yes, yes.
Yeah. Our chairman, sir, Orbashir Bora, sir. Our speaker for today, Dr. Subhash Gupta, sir. Our moderators for today's session, Dr. Mofid Zaman, sir. Dr. N.N. Das, sir. Dr. Konakeshwar Bhuya, sir. Dr. N.N. Ganguly, sir. Dr. Dhrubajyoti Bora, sir. And Dr. Hiranand Das, sir. All esteemed members of Assam State Chapter of ASI, my friends, and all my postgraduate students. We welcome you all again to this special series of programs that has been brought to you by Assam State Chapter of ASI. We are trying to bring the best surgeons to our home, a series that is trying to highlight the progress of surgery till today and its future, told to you by the leaders in that field. For this third episode today, we present to you Dr. Subhash Gupta, a maestro in liver surgery, who will provide the insights and wisdom in the various all along his 30 years of experience. Dr. Subhash Gupta doesn't need any introduction. He is the chairman of Max Center for Liver and Biliary Sciences, Max Super Specialty Hospital, Saket. Having his education from All India Institute of Medical Sciences and a vast experience in many hospitals like Indraprastha Apollo Hospital, Gangaram Hospital, St. James University Hospital, Leeds, Queen Elizabeth Medical Center, Birmingham, and the All India Institute of Medical Sciences. He has accomplished and has many awards to his own. He has pioneered the development of living donor liver transplant in India. He has published more than 30 papers on different aspects of living donor live transplant in very indexed journals all over the world. He has been honored with the position of the professorship in surgery from Apollo Health Education and Research Foundation. He has been awarded the Honorary Professor of Kazakhstan, and in 2016, the Medical Council of India has awarded him with the prestigious B.C. Roy Award. The Institute of Postgraduate Education and Medical Research, Kolkata, has also honored him with the position of Professor of Liver Transplantation. Delhi Medical Association has awarded him with a gold medal in 2005. In 2012, they have honored him with the award Vishist Chikitsa Ratni, Distinguished Clinician, on Doctor's Day. In 2014, he and his team were one of the finalists of the category Surgical Team of the Year for the BMJ India Awards. Apollo Health Foundation has also made him an honorary professor of surgery. Sir, we welcome you to this forum of Assam State Chapter of ASI, and we are honored to have you amongst us. Please enlighten us with your knowledge. Over to you, sir.
Thank you very much for having me on the. Can you hear me?
Yeah, we can hear you, sir.
Thank you very much for having me here, for all those kind words. And I'm sure none of that is true, but still,
That is your humbleness, sir.
I accept that with due humility. But so when I was asked by the Assam chapter to speak on this topic, I thought it'll be very difficult because it is like trying to pass on. It's a very focused topic I was asked to speak on. I've been asked to speak on only on the techniques. I've not been asked to speak on indication or assessment of liver reserve or remnant liver volume. So I thought what I have to do is just put together what I've been doing over the years and present it to to this audience, so that the true purpose of this meeting can be served. So I'll start by sharing my screen. let's see if that happens easily or not. Sometimes with Zoom, one is. So just tell me whether you can see my screen. Can you see my screen?
No, not yet, sir.
Okay, so let me. Then I have to. Oh, I think I have to click share screen. I think
Yes.
shared screen. Now, can you see my screen?
Yes, sir.
Yeah, we can see your screen, sir.
So what I'm going. So
Screen.
the topic has been very focused topic, and I'm going to restrict to this. Unfortunately, I had very little time to prepare this, so I have made error that I've copied a video from another source, which is a very but that kind of video sums up all that I've been doing, and and I hope the audience will. It's not my original video, but it will still. I'm sure some of you have seen it before, but it will highlight many of the things that I have to say. Therefore, I thought I will just use that video later on. So in the talk, as I said, I won't discuss diagnosis. I won't discuss assessment of liver function or calculation of functional remnant liver volume. I will also not discuss maneuvers for augmenting remnant liver volume, such as ALPS or portal vein embolization or hepatic vein embolization or external beam radiotherapy. We'll just strictly make it a surgical talk and focus on techniques. Although laparoscopic liver surgery has made great advances, and in our unit also, one my colleague Dr. Shalin is doing a lot of it nowadays. But I thought today I will stay out of it because our experience is relatively recent and not yet. I don't think we become masters in it, so I will omit the laparoscopic part of it altogether. But just a brief slide, first slide on indications, because liver resection is required in a variety of disorders, gallbladder cancer, which is so common, primary tumors of the liver, such as adenoma, hemangioma, or benign conditions such as hydatid disease of the liver, and malignant tumors such as hepatocellular carcinoma, hepatoblastoma, hilar cholangiocarcinoma. Liver metastasis, the commonest, of course, is colorectal, and then, of course, non-colorectal and non-neuroendocrine metastatic tumor. They are also sometimes candidate for resection. Hepatic trauma, which even if a general surgeon doesn't want to do liver resection, every now and then he will encounter a patient of hepatic trauma, and then his skills would be needed to save the patient's life. And I will also not discuss living donor hepatectomy, as has been told by my friend of many years, Dr. Das, that I have not to talk about living donor hepatectomy at all. So why liver resection is a hot topic for surgeons? The main reason why it's such a hot topic for surgeons that it's a very challenging operation for an organ which is very vascular. Sometimes there are coagulation disorders associated with it. There's obviously portal hypertension, and sometimes it is very difficult to get adequate exposure, and some right lobe may be deep seated, and therefore any maneuver on the liver becomes exceedingly difficult. So liver resection always is a hot topic for surgeons because of the complexity of the operation. The moment they hear about liver, most surgeons including myself, start worrying that there'll be excessive blood loss, and they look at INR tests and they find that the INR is deranged. But one thing that I would like to highlight here, which is occasionally not very highlighted quite often, is that as the liver function deteriorates and as there is loss of anticoagulants, so is there a matched loss of procoagulants, and therefore the balanced hemostasis. So if we have this important thing in mind, then we'll realize that even in patients with very abnormal INR values or platelet values, the bleeding risk may not be that much. And the operative impression has far more reliability than any test result. And therefore, a close interaction with the anesthetist is important for decreasing blood loss. And so occasionally, of course, if you're in a transplant unit or a big liver unit, you can have real-time tests for coagulations such as thromboelastography in the theater itself. But by and large, I would like to stress that a close interaction with the anesthetist is far more important than any test to find out about bleeding risk in a person in whom you have to do liver resection. So when you start liver surgery, you'll find that in the beginning, the liver bleeding tends to be a little bit more than in any other patient. But gradually, with the stress of the surgery, the patient will tend to become hypercoagulable. And sometimes the anesthetist will put in transfused blood or transfuse plasma and platelet if they have to put lines. And by and large, this practice should be discouraged, because this early volume loading will cause more bleeding during the dissection and the transection phase. And of course, if excessive bleeding has occurred, then coagulopathy sets in. It is impossible to control bleeding. So right from the start, the surgeon must be on top of the bleeding. And I think this is one of the most important techniques in liver resection that I have to share with you. So amount of blood loss in the early phase is less, in the dissection phase, in the sort of dissection phase of vessels. When the transection of parenchyma starts happening, then of course there is a lot of bleeding and one has to be careful there. And later on in the final stages, you just have to ensure hemostasis has been achieved. So the message that I would like to share with you is that safe liver resection means no bleeding. Because if you have bleeding, then it increases the post-operative morbidity and mortality, and also decreases long-term outcome. And this has been shown by many surgeons, Yamamoto in surgery way back in 1994, and Kubi and others have shown that the blood loss must be prevented in liver resection. Sometimes I put this paper has recently got accepted for publication, that sometimes when you're dividing the bile duct or the side that you want to resect, you may end up with a sort of narrowing on the remnant side, and this can be easily corrected. If you have the gallbladder cystic duct area, then you can put a patch on it, and this can then ensure that there's no biliary structure or post-operative derangement of liver function post-operatively. So, what are the maneuvers to minimize blood loss? Some of them you already know, some of them I have alluded to, such as low central venous pressure. Then there are vascular occlusion techniques. Then there are anterior versus posterior approaches. Then there's anatomic and segmental resections, and there's use of parenchymal transection devices and post-transection hemostatic procedures. This is all important to minimize blood loss. So the fact that low central venous pressure reduces bleeding in liver surgery has been long known since 1998, and many groups have studied that a low CVP is essential in reducing the blood loss as compared to those who had a central venous pressure greater than 5. Nowadays, of course, we don't really measure the central venous pressure, but we ensure that no fluids are given prior to transection. Fluids only given after the transection. If necessary, blood pressure can be maintained with inotropes rather than with fluid. So keeping the central venous pressure low, of course, the theoretical risk of venous air embolism may be there, but it's rarely a problem. But if you do encounter this, then you quickly pour saline in the field, you put the head up, and you put the sort of head down, and you ask the anesthetist to do some positive pressure, and you can then ensure that there is no air embolism. But this is something obviously one needs to be careful. Now, there are other methods of preventing blood loss, such as smooth transection, and we find that multiple senior surgeons with regular breaks is the most important thing, because it's a very tiring surgery. Then, of course, you need to prevent simple things like clamp slippage, and most importantly, what we learned from experience is that after the transection is over, you must ask the anesthetist to increase the central venous pressure, volume overload, so that any clips and ties that were to slip, where would slip now rather than later. And all the clips, particularly on the IVC, we need to transfix. Otherwise, in the post-operative period, many of them, instead of being a LIGA clip, they'll be a LIGA slip. A lot of liver resection is accompanied with intraoperative ultrasound, particularly in the Western world and in the Japanese surgeons. And of course, it's a standard adjunct to theater. But in India, many surgeons are not familiar with intraoperative ultrasound, and quite often you have to call the ultrasonologist to help you. But by and large, what we found over the years, that the availability of CT angiogram has high quality CT angiogram has decreased the dependence on intraoperative ultrasound, and very rarely we find that there is a real need for intraoperative ultrasound. And further, the growth of living donor liver transplantation in India has allowed for greater understanding of liver vascular anatomy. So one of the key things that the ultrasound does is that it identifies the middle hepatic vein, and that helps you keep it on one side or the other. But with experience, once you've done a few liver dissections, you'll realize that the middle hepatic vein can be moved to one or the other side while transecting in the ischemic plane. So hepatic venules are important at this stage to recognize which is a hepatic venule and which is a portal triad. Because if you start for tracing the portal triad, then you may end up causes damage to the side that you want to preserve. So hepatic venules are thinner, they're bluer and relatively large, and they're fragile. A little bit of parenchymal device that you may be fond of using may cause it to rupture and start bleeding. So it's important to early on to recognize which is a hepatic venule and which is a portal radical. And if you encounter a hepatic venule, then in the beginning, if you want to, for example, you're going in the mid side of the mid plane of the liver, and you want the hepatic vein to be on the remnant, you will keep dividing it in such a way so that it moves to the side that you want to do it. And by this way, you will keep the middle vein to the side that you want it to be. And if you're using the Cusa, the setting can be lowered, and if there's any bleeding from there, you can hold it with the thumb forceps while you Cusa all around it, or you can even use the harmonic all around it while you're holding it, and then apply clips rather than trying to blindly put a clip. Hold it with thumb forceps, dissect around it with whatever device you're familiar with, and I've got a video to show you that later on. And this can be low, and then you can apply a clip rather than, because if you put a clip without mobilizing it, then you'll end up with a lot of more further damage. So this is a very favorite picture that I've shown at multiple places, and this is what we call the clamp test. So as you can see, the ischemic line between the liver has been marked nicely from the left and the right side. But also, if you use the clamp in this way, that means you clamp the root of the middle and the right hepatic vein. You can also clamp and demarcate the anterior sector of the right lobe. As you can see, this bluish area, this red area, and again normal area. So this is the area of the right lobe that is being drained by the middle hepatic vein. And of course, if you're doing liver transplants, you'd like to ensure that all the veins draining this area are reconstructed. But here I've shown you so that you wanted to identify segment 5 and 8 in your if you want to do a limited resection, this is one way you could do it easily. The upper part is 8 and lower part is segment 5. And this is also very important because occasionally what you'll find that one of the segment 8 veins have avulsed, and you're trying to take some stitches there, and the stitches won't hold and get worse and worse. What I suggest at this stage is that you do a Pringle maneuver and put a clamp in the same way as you've done the middle as you've done on the left and the middle vein, and then you'll find that the opening in the middle vein can very easily be repaired. And this is something that we published in 2017. And this is it shows you the groove. The sling is on the right hepatic vein, and this little opening that you see is just lateral to the left hepatic vein. And between these holes, your angle clamp will sit in. This will control the outflow. You will control the outflow with inflow with the Pringle maneuver. And then if there's an opening in the middle hepatic vein, you can repair it without any pressure, without any stress. So which brings me to vascular control. There are a number of ways you can do vascular control. You can do intrahepatic vascular control, or you can do extrahepatic vascular control. But first, let's talk about extrahepatic vascular control, in which the portal vein, hepatic artery, and bile duct followed up to their divisions, and the side that needs to be taken out, that side, the structures are dissected and divided, and the hepatic veins are dissected outside the liver. Now, as opposed to this, you have the intrahepatic approach, in which you do the transection first along the hepatic fissures and ligation of the pedicles directly within the liver. And you can have an anterior approach to this, or you can have a posterior approach to this. And again, I'll show you some videos of this, and you'll understand what I'm trying to say. So you make incision of the liver capsule around the porta hepatis, and then you can do a sort of segmental dissection of these triads, and then clamp it, which will mark the ischemic areas, and then you can gain control. So there are pros and cons of vascular control. Now, the advantage of if you do not want to control prior to resection, then you mobilize the lobe that you want to resect. Then you transection of the liver parenchyma, inflow and outflow of the area to be resected with no other vascular control. And the big advantage is that you will then be tying the radicals only of the side that you want to take out. So there's no risk of erroneous ligation. And the risk of bleeding by not getting inflow control by careful transection techniques by use of devices. So here, doing a right hepatectomy, and with middle vein, we want to take out together with the right lobe, and you can see we've gained control of the middle hepatic vein within the liver. So this is control after transection of the liver. Now, there are sort of vascular control methods. There are inflow occlusion, and then there are, of course, both inflow and outflow occlusion. Inflow occlusion can be generally it can be intermittent or continuous, or there can be a selective inflow occlusion, or you can have both inflow and outflow occlusion. So this is an example where you put a finger from the right to the left into the by opening the sort of feeling the free edge of the gastrohepatic omentum, and you sling it, and you've got total inflow occlusion, the so-called Pringle maneuver. Even now, it's a very useful, and now that with laparoscopic becoming so popular, I find many of the surgeons will do this. Laparoscopic surgeons will do this first before they even touch the liver. Now, total inflow occlusion studied by many surgeons, and intermittent Pringle maneuver in 50 patients, and the blood loss was obviously much less whenever the Pringle maneuver was used as compared to when it was not. And I still think, though a lot of people debate that whether the clamping is not necessary with modern devices, and in fact most of the hepatectomies that we do without clamping, but I think that in pathological cases clamping should be done, not only to ease the dissection but also for the safety of the patient. How long can you clamp for? You can clamp for up to 60 minutes, and this has been considered the safe upper limit. Or you can do intermittent clamping. That means you clamp between 10 to 20 minutes and give a 5-minute gap. And total ischemic durations up to 90 minutes has been used safely. However, randomized control trials between continuous and intermittent clamping have not shown any difference. But generally, most surgeons, including myself, and I know a lot of liver surgeons now, would like to do intermittent clamping rather than continuous clamping. In fact, even if you've done all the preliminary maneuvers, even one clamping can allow you to resect the area that you want to resect. It can be done so quickly. On the other hand, there is, of course, where patients with cirrhotic patients, where you want to preserve liver function, you can do selective vascular occlusion. That means you limit ischemia to the side of the liver that you want to remove, and also results in less stasis and venous hypertension in the mesentery and the bowel. First was described Bismuth and McCucci. That means you dissect the artery, portal element, venous branches of one side, the temporarily occluded, and results in a significant reduction in blood loss compared to no occlusion. So this is one picture here that you can see that we have dissected. This is we're going to do a posterior posterior sectorectomy, and you can see that we've looped. The blue sling is on the posterior portal vein, and you can see the anterior hepatic artery, the posterior hepatic artery, and both are going to sling. The demarcation line has already been marked on the posterior sector, and you can then proceed along the ischemic line. And this sulcus, Groovius sulcus, will help you in identifying which plane that you need to go inferiorly. Then you have even bigger techniques for, even more difficult techniques for tumors that will not come out, it can be taken out easily. So total hepatic vascular occlusion is some technique that most liver surgeons, particularly those engaged in transplantation, will often use it. That means you put a clamp on the in the free edge of the gastrohepatic omentum. You loop the inferior cava. You put a clamp there, and in the same, with that finger you can create a sort of plane right till the forward, because there are no lumbar veins in this region. You put a clamp on that, and you then just chop off the liver, and then you repair all the veins, whatever you want to do. But by and large, this is sometimes not well tolerated, and only and you may need to use a veno-venous bypass. So by and large, most surgeons will not use this technique anymore, and they will dissect it off gradually. Even in a cirrhotic liver, they'll dissect it off by tying the small hepatic veins rather than causing major hemodynamic disturbance. So this is a picture of a total hepatic vascular occlusion. The portal triad has been occluded, the top and cava has been occluded, and you can actually have, but you need to obviously volume overload the patient. You do a trial clamping before that, and it'll cause a major sort of hemodynamic changes in the individual. But sometimes it is necessary, and I'll show you where you may need to do this later on in the presentation. So it has been studied by prospective trials by Belghetti very early on in 1996, and they found that it was no significant difference in blood loss with total vascular occlusion or as compared to Pringle maneuver. So by and large, it is reserved for large deep-seated tumors or tumors abutting hepatic veins and IVC, hypervascular lesions, and patients with increased right-sided heart pressures. Apart from this, the very limited role of total hepatic vascular occlusion. Now, this is one maneuver that most surgeons, sometimes you don't have a very cooperative anesthetist, and your central venous pressure may remain high, and you're trying to do a resection. So one maneuver that can aid you is by just clamping the lower cava will bring down the central venous pressure, and you can then proceed safely with your resection rather than waiting for the central venous pressure to come down by the help of the anesthetist. So you can sort of clamp the lower cava and then CVP will come down. You can also have a total exclusion of liver flow by looping and occluding the right vein, the left and middle vein, the portal triads, and whether the portal flow keeps going on. This is again tumors with hepatocaval junction. This may be necessary, but of course this will require all the phrenocaval dissociation to be done, and I'll show you some slides of that later on. And this is occasionally the caudate veins may cause some back bleeding as they get torn by this, but by and large this is something that can be used without hemodynamic compromise. So this is another example of isolated total caval clamping. So you have blood flow maintained to the side that you want to preserve. You clamped the bottom cava, but at the top you've clamped the side that you want to take out. So there's flow maintained through the portal system into the top cava, and this will perfuse the remnant liver. And this is and we had to use this recently in somebody who had a tumor like this. There's a tumor from segment 7 that was going into the IVC, and we had to use this maneuver. Otherwise, it would not have been possible to do this. So, summary of vascular control measures. They are important. However, 90% of liver resection is possible without vascular control. And as you know, in living donor liver transplant transactions done without vascular control, mainly because there have been technical advances like CUSA, argon beam coagulator, low central venous anesthesia, and improved understanding of segmental anatomy of the liver. Now, So that's inflow techniques. Then I'll briefly say 1 or 2 slides on liver mobilization. That is, the left lobe resections and lateral lobe resections are easy because it's very easy to mobilize it. But with the experience and with the sort of adequate exposure and good retractors, it is possible to rotate the right lobe out of the abdomen much the same way as the left lobe, and it can then, it is between your it is between your two hands to and you can then sort of compress it if it's bleeding, and then you divide and this you can get this situation by dividing the inferior hepatic vein, short hepatic veins, and division of hepatocaval ligament. And also, I talked about phrenocaval dissociation, which I meant was that the phrenic veins draining into the right hepatic vein must be ligated. Otherwise, you'll be putting a clamp on the diaphragm rather than on the hepatic vein, and slippage of that clamp can be disastrous. So no, and don't apply any clips on venous branches where the clamp is likely to be applied, because then, of course, the clamp won't be able to occlude the vein appropriately, and ensure that there's adequate muscle relaxant. So here's some slides of how phrenic veins, one phrenic vein has been tied in this, another 2-3 veins, so the liver is coming out of it, and then you free it with the hepatocaval ligament has been freed. So the right lobe is almost in your hand now. And when you apply a clamp like this, then obviously your clamp won't slip. Whereas if you were to apply the clamp on the diaphragm, it would slip. This is very important in sort of ensuring that you don't have ruptured veins causing excessive bleeding. So try, although one is tempted to hang the liver quite early on, but try and dissect segment 5 and 8 veins if you're doing a right hepatectomy, left hepatectomy, before you do the hanging maneuver. Because if you do it too early on, then you'll find that these veins can rupture and you can have torrential bleeding. So try and, after you loop them, only then you try and sort of hang the liver so that you can quickly complete the transection. So this is another slide to tell you how the right lobe has been mobilized of the cava, so that when you're using your diathermy from the top, then you will not injure the cava below and therefore not have excessive bleeding. Now, this is not my video, and I'm going to use the audio of the presentation itself. I acknowledge this is Dr. Sugiora's presentation, and it's a very elegant demonstration of what you need to know.
Isolation for the anatomic liver resection, including open, laparoscopic, and robotic approach, mostly in the same way. This schema shows our novel concept of the liver anatomy based on Laennec's capsule. The red line represents Laennec's capsule, which covers not only the entire surface of the liver, but also the intrahepatic parenchyma around the Glisonian pedicles and the hepatic veins. According to the concept, there exist gaps between the Glisonian pedicles and Laennec's capsule, and gave a theoretical background to extrahepatic Glisonian pedicle isolation, but the procedure has not been standardized. Only the 6 gates indicated by 4 anatomical landmarks allow us extrahepatic approach. By connecting 2 gates, we can isolate second-order Glisonian pedicle extrahepatically at will. For example, by connecting the gate 4 and 5, extrahepatic anterior Glisonian pedicle isolation can be achieved. First, the right-sided Glisonian pedicle isolation techniques are demonstrated. This schema shows the vertical section at the main portal fissure. As shown, the gap between the cystic plate and Laennec's capsule is continuous to the anterior Glisonian pedicle. Therefore, for the right-sided extrahepatic Glisonian pedicle isolation, we basically start from the cystic plate cholecystectomy. At first, only serosa was divided circumferentially, and you can recognize the shiny surface of Laennec's capsule beneath the serosa. The boundary between the neck and body of the gallbladder, the gap between the cystic plate and Laennec capsule, could be easily entered, and the gallbladder was taped. Upward blunt dissection is sufficient to peel off the cystic plate from Laennec's capsule. It is likely that there is a grain of the turf toward the fundus. The shiny surface of Laennec's capsule covering the liver bed is clearly observed. After the cystic plate cholecystectomy was completed, we moved on to anterior Glissonian pedicle isolation. The anterior Glissonian pedicle was exposed naturally. An anchor was isolated and divided carefully. By connecting the gate 5 and 4, the anterior Glissonian pedicle was isolated extrahepatically and taped. Laparoscopically, the same procedure can be applied. We will present the procedures from the cystic plate cholecystectomy to anterior Glissonian pedicle isolation and G8 isolation. After the division of the serosa, the shiny surface of Lanex capsule was exposed by upward blunt dissection. You can clearly recognize the shiny surface of Lanex capsule covering the liver bed. The anterior Glissonian pedicle was exposed, anchors were isolated and divided carefully. Division of anchors enabled us to enter the gap between the Glissonian pedicle and Lanex capsule. Then the anterior Glissonian pedicle was isolated easily. Further on, the anterior Glissonian pedicle could be pulled out to the hepatic hilum, and the Glissonian pedicle 5 or G5 was isolated. Then the G8 was isolated and taped by subtraction method and clamped. Segment 8 was visualized as the ischemic area. Robotic approach was also available in the same way. The anterior Glissonian pedicle was isolated. G5 was isolated easier by the robotic articulation. G8 was also isolated easier using subtraction method. G5 and G8 were isolated extrahepatically. G8 was clamped, and not only demarcation but also the counter-staining using ICG fluorescence was useful to identify the segment 8 accurately. Even the peripheral Glissonian pedicles could be pulled out to the hilum and isolated using the repeated subtraction method. The posterior Glissonian pedicle was isolated. Isolation of G1C was followed by connecting the gate 5 and 6 to isolate the posterior Glissonian pedicle. After posterior Glissonian pedicle isolation, G6 and G7 could be isolated separately by the subtraction method. Second, the left-sided Glissonian pedicle isolation will be presented. This schema represents the vertical section at the umbilical fissure, the gate 1 at the caudal part of the Aranteus plate, and the gate 2 at the root of the round ligament should be confirmed. Left lateral section Glissonian pedicle and G2, G3 isolation will be shown. At the attachment of the lesser omentum, the Aranteus plate was detached. The gate 1 could be approached at the caudal side. Then, the gate 2 was approached at the root of the round ligament. Connecting the gate 2 and 1, the Glissonian pedicle of the lateral section or G2 plus G3 was isolated and taped to end block. Behind the Aranteus plate, the Glissonian pedicle of the Spiegel lobe or G1L could be clearly identified, isolated, and taped. Robotic approach was also available in the same way. After isolating the Aranteus plate, the gate 1 is approached and then the gate 2 was also approached. By connecting the gate 2 and 1, G2 plus G3 was isolated en bloc, and each pedicle was isolated using subtraction method. The medial Glisonian pedicle, or G4, could be isolated, connecting the gate 2 and 3. Laparoscopically, the medial Glisonian pedicle could be isolated in the same way. At first, the root of the round ligament was exposed. The gate 2 was approached. Next, the gate 3 was approached at the right side of the root of the umbilical portion. By connecting the gate 2 and 3, the medial Glisonian pedicle, or G4, was isolated. G4 could be clamped, and the demarcation area was confirmed. The left Glisonian pedicle, or G2 plus 3 plus 4, could be isolated, connecting the gate 3 and 1. The left Glisonian pedicle was isolated en bloc. Laparoscopic approach was also available in the same way, by connecting the gate 3 and 1. At first, the gate 3 was approached by dividing an anchor. Next, the Arrhenius plate was detached and the gate 1 was approached. The left Glisonian pedicle was isolated by connecting the gate 3 and 1. The isolated left Glisonian pedicle was simply divided using the stapler. The demarcation area was identified. Even for the caudate lobe, extrahepatic Glisonian pedicle first approach is possible. After isolating all the second-order Glisonian pedicles at the hilum, caudate Glisonian pedicles could be isolated extrahepatically using subtraction method. In the case, the Spiegel lobe pedicle, the caudate process pedicle or G1C, and 2 paracable pedicles were isolated and divided before parenchymal dissection. The Spiegel lobe pedicle was divided. G1C was also divided. After dividing all the caudate pedicles, the dorsal side of the hilum became empty, and isolated total caudate lobectomy was safely achieved. Extrahepatic Glisonian pedicle isolation technique has reached standardization based on Lanex capsule isolation for the anatomy.
So that was a very sort of demonstrated how you can get an extra Glisonian approach to extrahepatic Glisonian approach to various segments of the liver. So after having isolated the inflow to the segment that you want to remove, then comes how you transect the liver, and all devices seem equally effective. And experience of transection comes from repeatedly doing the procedure, and the intrahepatic vessels come in vision. Cheliclysis may be equally effective. Of course, our own preference is the CUSA, and the CUSA exposes the vessels that you want to clip. You can then use bipolar diathermy, or you can use simple monocrolar diathermy, and you can still get the same effect. So now I have a video that will show you how to transect the liver in by different methods, different devices that we have done. So you can, in this will show you 4 different methods. The Kelly clamp clisis, which is one of the oldest techniques and still I think very effective. And in this, you use a fine artery forceps after marking the ischemic line, and remember this we are doing without ischemic, without inflow occlusion. So you mark the ischemic line, and then you can proceed with using a mosquito and artery forceps, and you can make good progress. And at many times we've done this, and it is just as good really as a in some of the newer devices. So you can see that all the vessels are exposed one by one, and so use the tip of it to crush the tissue, and the fibrous part, the vessels remain. Then you can tie them, ligate them, and you can like this go on bloodlessly, and you can sort of do this right till the end. So the cheliclysis still quite often, if the QSA is not working, or and then you know, we often have to resort to this, and you can then gain control of the vessels that you want to from within. And I must say that it is you know, this method it still has its charms, and I will often demonstrate it to our residents and fellows that you don't need complicated sort of equipment to do a nice liver resection without blood loss. And by this simple method, all the vessels are getting exposed, and you follow the same technique. Somebody is sucking the blood out. There's, and remember, there is no inflow occlusion while this is happening bloodlessly. This is something that we it was done from one of our own cases. And how deep we've already gone. We were taken for segment 5, and we'll soon be able to encircle the segment 8 vein as well. So next is what we use commonly, which is the ultrasonic dissector. The principle is that the tip has a vibrating rod, which delivers energy, and parenchyma, which has higher content of water, will get will be injured, and the fibrous part vessels will remain skeletonized. And so we do a right using QSA. This is a device that is very easy to teach to all our fellows, and many of our surgeons have become very skilled in using QSA and Atham. And really you can do fairly bloodless, and of course you have a bit of charring that you can see that you did not see in the cheliclysis method. And the big advantage in this is that you can go around the vessels, intrahepatic vessels, segment middle vein branches that you want to take, and you can use this again very effectively. And I must say, this is our favorite device that we use. I've experienced with all the different devices. So in the beginning you can do a bit fast, you can use a harmonic to do it fast, but when you go deeper down, when the segment 5 or the middle vein branches, the middle vein itself comes in, then you have to go do it a bit slowly. And this is where you can see that segment 5 branch has been looped, and this is in fact, this is the complete middle vein that has been exposed within the liver, and we'll sort of take it. I will fire a stapler across it to remove it, and then will you and if you want, you know, it can be used for reconstruction. So the QSA is really a wonderful device as far as, and made everyone a liver surgeon. In the beginning, of course, you know, when Proline came, everybody became a vascular surgeon, because only in those days we were using lubricated silk, whereas with the QSA you can have a controlled sort of splitting of the liver without some, you know, you can do and it may seem slow, but with time, with experience, you can actually complete the transaction in less than an hour. And some of the newer laparoscopic surgeries that we've seen, so that segment 8 vein that is being looped now, so both the veins and the have been looped rather than and then they can be dissected, and they can be reconstructed on the back table. Then after this, we will show you how to use the water jet, which is also quite popular in many places. The spillage and aerosol, so a lot of people will not use it. But before the water jet, I'll show you the endo surgery, the harmonic scalpel. Of course, this is a slightly older video that we made when I was in working in Apollo. But nowadays, the newer devices have much smaller blades, and they're ideal for liver resection, especially. So there's a peripheral tumor here, and and the big advantage of harmonic is that you can do it very quickly. And so the harmonic scalpel can, you know, in a cirrhotic person, you can hardly have any bleeding. And with experience, you learn that The vessels also can be identified by using. So you in harmonic, what you do, you apply the jaws on the area that you want to work it slowly and keep pressing it until it gives way, rather than, and you can then you can do a fairly quick resection using the harmonic scalpel. And here, in fact, this resection was done in less than 15 minutes. Quite a large area of the liver that needed to be resected, and the harmonic scalpel is in that way. And this is recently becoming more popular, particularly with the surgeons who are keen to do robotic liver resection. They find, because they don't have a sort of a harmonic they don't have a accuser, so most of the liver resection are done by the robotic method, is by using this. So this is a very quick and rapid resection. A lot of livers remaining, so you don't worry about the remnant. And interestingly, there's some worry that it may cause bile leak, but actually it does not cause major bile leak. Finally, coming on to the water jet, which we've had some experience with, and it is also a very fast device. So you have to learn to use it, and it uses a sort of a high pressure water jet, and it destroys the parenchyma, but leaves behind the parenchymal cells. So this is something that we used in the past, but we don't use it nowadays that much, because although it's good method, but the probe is costlier. Whereas the Cusa probe same one will last forever, but the water jet probe has to be used every time, and therefore it's not as popular as the as a but in some situations we found that the water jet is actually much better and faster, particularly in livers that are tough, and used properly you can actually not have any spray, and you can end up transecting the liver. It's quite nice actually, and we at one time I used to use it a lot, till the cost of the probe became so much that each patient had to pay another additional 50 lakhs, and therefore we stopped using it and changed to robotic altogether. So change to Cusa altogether. But again, it's a very effective device, in the sense that it causes a very quick transaction, and the water jet, and it really some fears that it may cause splaying. It doesn't really happen, and the groups, particularly in Germany, and that you can see the middle hepatic vein pulsating there, and we're following its course all the way to the where it's going to insert on the left side, on to the where it's going to insert at the top of the cava. So this is water jet that can be used. But I think the most popular devices nowadays are the harmonic scalpel, and the different types of harmonic scalpel. The different surgeons groups has used different type, the Thunderbolt and the sort of normal harmonic. So this is the middle hepatic vein that has been looped here, and this is going to be taken out a bit later on. So in liver resection, the important thing is to try and get hold of the segment 5 and 8 veins, rather than trying to resect the liver. So once you get hold of the segment 5 and 8 veins, remaining transection becomes relatively easy. So that is the goal, should be to try and get the 5 and 8s identified quickly. Because once you've done that, then in the remaining areas, once you've found a sizable 5 and sizable 8, then the remaining liver can be transected very, very quickly, really. So that's the finish of this video. Now, there are large bulky tumors that will require what we call the anterior approach. So you ligate the inflow vessels. You don't need to divide them. And you can use a finger from above between the right and middle vein junction, and a finger from below. And you can make the two fingers meet almost as when you do a transhiatal esophagectomy. You can make the two fingers meet and push the liver up, and then you can pass a tape and pull the liver forward, and this will allow for easy transection. So this is the approach we use for a tumor of this size. We use the anterior approach. We did not try and mobilize the liver because we worried that it will rupture. The caudate lobe resections can also be done by sort of, we showed you in that gate approach, and you can sort of divide the Ranchis ligament, gastropatic ligament, get the pedicles, and you do a caudate lobectomy. Now I'll show you few things that most surgeons will not be familiar with. That vascular reconstruction in liver resection, portal vein reconstruction, quite often it's done. Hepatic artery reconstruction can also be done, particularly if you have the experience. And sometimes this will allow a smaller area of the liver to be resected rather than big area. So this one tumor here that you can see here, the left portal vein is gone, and the right hepatic artery, as you can see in the arrow here, is also occluded. So the left hepatic artery is gone, right hepatic artery is gone, and therefore this would ordinarily be unresectable. But using vascular techniques that we learned from living donor liver transplanted, we resected the left lobe and we reconstructed the right hepatic artery, as you can see here. And this is then reconstructed the second order, the right hepatic ducts with hepaticojejunostomy. And this was a specimen that came out. What about staplers? Rarely used for parenchymal transection, but expensive, but can be used, but is associated with a high bile leak. I'll show you some things that we do quite frequently with this cholangiocarcinoma with no touch technique. And so you resect all the structures surrounding it. For example, you have a tumor on the right side, then you would divide the right hepatic artery just as it comes off the hepatic artery. You'll divide the portal vein and then reconstruct, and thereby you don't disturb the tumor at all. And this has been shown by German groups that's very good in giving you a better survival. Similarly, you can do a sort of good survival with this technique. Now, Professor Mohammed Rel and all describe this Rex approach for cholangiocarcinoma. Essentially, what you do is you locate the branches of P2, P3, put a clamp, put a graft, and then join it with the portal vein, and then you can remove the entire sort of specimen. This is the hepatic artery there. So finally, in coming to the end of this long talk, that liver resection requires planning. Assessment of liver function, remnant liver volume, that's another chapter. I didn't touch on that. Liver mobilization, some form of inflow-outflow occlusion, meticulous transection technique, and in the end, do a hemostasis. Thank you very much for listening to me for more than an hour. Over to you, Dr. Das and Dr. Barua.
Thank you, Subhas, for an elaborate talk on this liver resection. So there must be a couple of questions from the audience. So I just want to start from my side. Regarding the hepatic vein, middle hepatic vein, there is always a fear psychosis that we may go to the left, we may, if we go for a, if you want to keep the middle hepatic vein on the remnant side, there is always a, chance of you may go to the left also. So do you think that is it safer to stay at least a few millimeter right of the line of ischemia?
You can do that. I've got your question. I've understood your question quite easily. I've got your question clearly. But if you go too much to the right, you'll be in the, you'll encounter a lot of radicals, and that'll make your resection quite messy. So I would suggest that one should stay in the ischemic line itself. Any venule that you find, you tie it and push it to the other side, and still say just to the right of it, rather than going from the beginning, planned beginning to stay sort of too much to the right, so that you don't injure the vein. This is not something that believe me. But because, I mean, if you want to do a fast transaction, but of course, if you want to be, you want to be completely safe, then what you're suggesting we could do. But we find it that it's much faster by staying in the plane rather than moving to the right.
Yeah, because in a transplant scenario, you have to keep always to the, because if you want to keep the middle hepatic vein on the remnant side, you have to stay strictly on the right side of the middle hepatic vein. You cannot compromise on that. That's why, I say, so only you want to say you should stick to the line of ischemia.
Yeah, because it makes for a faster transaction rather than see with the preserving the parenchyma on the middle vein. will not add to the remnant volume. So even if you bear the middle vein, it doesn't really matter. It will still serve the purpose.
Okay, thank you. And regarding, in this HCC excision, because, there is always the cirrhotic changes in the liver. Almost 90% of the liver is cirrhotic in the HCC. So whenever we plan for a HCC, so we have to do a cirrhotic environment. And regarding at that, there's the clamping of this porta. What you suggest actually? How far? How much time we should clamp the porta, because liver is already in a very compromised stage.
Yeah, I think if you are in cirrhosis, if you have to do a major hepatectomy, that means more than uh, two lobes, then you should think about it multiple times before doing it. That is one. Of course, there are a number of ways. The method that we follow for resection in cirrhosis is that the platelet count should be more than 100,000. There should not be any ascites. The bilirubin should be less than 1.5, and the INR should be less than 1.4. We do not actually measure portal pressures, but we ensure that the remaining liver is at least 50%. If you by excluding the tumor volume. So that's something that we do. But now recently ICG has become available. So some groups have started ICG, but we haven't yet started using ICG because we find that it doesn't really add to the information. But what really you should one aim for, if it's a segment 8 tumor or then you must try and do a limited dissection. Some of the techniques I showed you, that how you can either if you can use the sort of selectively clamping the anterior pedicle or posterior pedicle, or if you are not you don't feel comfortable doing it, then you can still mark the boundaries by the method I showed you, by clamping the middle and the left hepatic vein at the top and the right hepatic artery at the bottom. Then the anterior segment will be visualized quite nice. Actually, the most difficult resection is the segment 8 resection, I feel, because that you may injure the vessels easily. And therefore, it is important that you should know the boundaries. The anterior section from the video that I've taken from our Japanese colleagues, that shows you how you can mark the anterior pedicle. You can pick it up, clamp it, and demarcate it nicely.
And do we think that esophageal varices is a contraindication for?
If there are esophageal varices, I think one should not, I mean, grade 1, I don't know, but anything more than that, you should not think of doing liver resection, because there are many ways of, because there's straight away if there are grade 2 or more varices, then your HPPG is going to be more than 10. And most liver resections are contraindicated if HPPG is more than 10.
Dr. Gupta.
Yeah.
Yes. Very nice presentation. This is Dr. Zaman. I have two questions for you.
Mm-hmm.
And number one is, personally, do you prefer extrahepatic control or intrahepatic control of the pedicle?
I actually use intrahepatic control for lesions in segment 8. Because I find it much easier to get the control from within. I do not do the video that I've shown, but I've included it for the teaching purposes, because this theory of this gating theory and how to get extrahepatic control is becoming increasingly popular nowadays. And therefore it is important that we learn how to get into this pedicle. That's why I showed it. But I actually get the pedicles for segment 8 after by the intrahepatic approach. That means we dissect, we use the accusa or the harmonic in the area, in the ischemic area, and get the pedicles from within. And that's also a very effective method. We've done huge number of segment 8 dissections, and it works quite nicely.
While doing a right hepatectomy, do you leave the bile duct to the last?
Yes, I do keep it right till the end. Yes. Because what I do is that I actually do it in a very different way. I don't divide the structures. I only put a tie on it to make a ischemic. Then I'll divide the caudate. And then I'll use my finger from behind and use the accusa with my left hand. Then that'll create a hole in front of the on top of the bile duct and everything. And then I'll use the sling to pull the liver up to complete the transection. And this way it is very fast. And then divide everything right at the end. Because once you lose support of the structure, sometimes you can end up with excessive bleeding.
Okay. And at the right hepatectomy again, do you think a hanging tumor is more amenable to resection than non-hanging one?
I think both can be done quite nicely. The hanging one is, of course, can be done very quickly without
Yeah, we found it
difficulty.
easier.
But quite often you'll find that the when you what appears as a hanging tumor on on imaging, but actually has a broad base, and you're much better off doing a formal resection rather than trying. Then, in fact, we had one patient who was who the surgeons reported as a hanging tumor. So it's taken up by one of the surgeons to do a, he thought he'll just fire a stapler across and get it out. But actually, it was he had to come to us in emergency, and we did a formal right posterior sectorectomy, and that was like kind of bloodless. But so it may be better to do it in a formal manner rather than by just because the base sometimes is quite the tumor. It may be most of it may be exophytic, but the base is quite deep seated.
And regarding this water jet dissection, we have not seen it, we have heard it, and it is said to be very messy affair. But
It's
in
not, as you
your
saw in
pictures,
the
I saw
video.
it
As you saw in the video, it's not messy at all. It's you just have to learn how to
Yeah.
use it. Very fast. It's very good, and it's very good for cirrhotic livers. I've used it in my old hospital where in Apollo, I purchased it. But now, of course, we don't, because the probe. Every time you want to use the probe, it'll cost you extra money. Whereas the CUSA probe remains, all you need is, once you bought it, it'll stay with you for lifetime. In fact, our CUSA machines that we bought 10, 15 years ago are still working.
Okay, fine. Thank you so much.
Hello.
Professor Subhas, here in the Northeast or in Assam, so gallbladder cancer is very common, okay? And our lot of surgeons do, segment 5 and segment 4B transaction. So can you give some tips, how far to do and, what should be the limit and all? Because because it is very commonly done for
I
CA
think
liver.
the first thing is those gallbladder cancers which present with jaundice, we should not touch them as a resection. That's the first teaching point. So the ones which are most common, the ones which are mostly in the fundus. So the teaching point that I would like to say here is that ligate the cystic duct, keep a little bit of liver tissue on top of the portal structures, and after that stay to the right of the falciform ligament, and then go quite deep into the on the anterior surface of the liver, and then again similarly you can go very or too much, quite a bit onto include almost all of segment 5, as I showed you with the sort of clamp test. You can demarcate the boundary of segment 5 with the clamp test, and then once you have cleared push the cystic, divide the cystic duct, left a little bit of liver tissue, then you are safe. Then you can very rapidly go transecting the liver. What you will encounter is somewhere you will encounter the middle hepatic vein just in line with the gallbladder plane, and there you will be a little slow. Identify that, ligate it, and then you can do this very quickly. So
we should not touch the segment 4B, no?
You should not touch. I call it segment 4A. The top one is 4A. I use the 4B as the lower part. The 4B, of course, to remove.
You have to remove, yeah. 4B and 5. Okay.
4B and 5.
Hello.
Yeah.
Good evening, sir.
Good evening. Good evening.
It's a very good presentation. We have heard two back-to-back liver section from one of Dr. Nitin Das and one from you, sir. So I want to know about liver dissection in trauma.
Yeah, that's a very important question, and I wanted to cover it.
Yeah.
Now, I think the most trauma would be managed by a midline incision. Am I correct?
Yeah.
Okay.
Yeah.
So it is very important how you place the retractors for liver resection. The normal way when you put the retractors, we have the blades sort of pointing upwards. So when you want to do, when you're using a midline resection, first and foremost important thing is to ensure that the blades are pointing downwards towards the patient's feet of your retractor. And then when you apply the retractors in this position, you'll find that you'll get as good an exposure as you get with with a Mercedes-Benz costal incision. So the first and foremost thing, if you have a liver trauma, is to, of course, you extend the midline incision, but change the retractor so that your blades can be the blades are sort of pointing towards the feet so that you can get exposed. And believe me, with this you can get entire exposure of the of the right lobe at all. It's the left lobe is not a problem for most surgeons. It's usually the right lobe in trauma. And quickly, in fact, once you've got the exposure, one of your assistants can retract the right lobe. In fact, you can cut the thing. You can divide the sort of right triangular ligament blindly, and then do not worry about the bleeding. And once you've done this, then the whole thing is in your hand, and you can just quickly transect and control the bleeding. But you must change the setting of the retractors when you're using a midline incision, because to change the incision, and it's not won't you lose a lot of time and patient would be bleeding a lot. Of course, you would have done inflow occlusion. That is very simple, total inflow occlusion, and you change the retractor blades. Your assistant retracts from the left hand side, and with the scissors you quickly, because it's completely avascular, particularly trauma, there's no portal hypertension. This plane is completely avascular. And if your anesthetist has a very high CVP, you can just take a clamp, put it on the bottom cava, and you'll find that the thing is quite easy. The CVP.
Dr. Subhash. Hello.
Dr. Gangli, hello, sir.
After a long time, how are you?
Long time, good.
Yeah, you're looking good. Yeah.
Very nice talk. Thank you.
Your talk was basically on how I do it. So I definitely expected that you will not touch these 2 points. So, but for the benefit of our audience, I need you to just tell us a little bit about subsegmental anatomy of the concept of liver by Professor Nimura and Kuino together. And I think in Istanbul, Professor Nimura told us about the techniques of doing subsegmental resection.
Yeah,
and second is, you did not tell us anything about non-anatomical resection of liver, and which probably I presented in Bombay, and your student, then Soin, also put in some comments. And third is Babu Rao Konetu's method of doing liver resection by diathermy. So this probably you don't do, so you haven't said us. Plus, just give us a little bit of ideas.
Okay, let's take a one by one thing. How doing a non-anatomical is the most easy question to answer. Non-anatomical has taken a big sort of leap and surge, but many laparoscopic surgeons now want to do liver resection. And the data, as long as you have good margin, data seems that it's as good as far as anatomical resection concerned.
Thank you.
Now, so there is no, I mean, right now there's no debate on whether it should be anatomical and non, as long as you have a good 1 centimeter margin around it, you'll get equally results. Now, the Babu Rao's method of diathermy, the multiple ways you can use it. I've shown you 4 common methods that we've used: the cheliclysis, the CUSA, the water jet, and harmonic scalpel. And you can use the diathermy as well to use it. But some of the fancier things like Habib's device and all, I think they should be thrown to the dustbin, because they actually don't add any value to anything.
True that.
Then talking about segmental resections for segment 2, segment 3, quite easy, because as I showed you in the slide, you can isolate all the pedicles of segment 2, segment 3, segment 4. I showed you how to isolate segment 4 pedicle. I showed you how you can isolate segment anterior sector pedicles, and I also just showed you how you can isolate posterior sector pedicles in one of the slides. So segmental and non-segmental subsegmental resections can be done. But currently, with the practical teaching point is, if you have access to a transecting device, then you can pretty much resect whatever areas that you want, because you can show the vessels within. While you're transecting, you can show the middle vein, left vein, right vein within the liver, and you can do transect. So it's become relatively easy. So I hope this answers most of your
all of my queries. Thank you. Thank you very much. It's nice to see you after so many days or years rather.
Thank you, Dr. Gandhi. Thank you.
Dr. Subhas, one thing I want to ask that what should be the minimum bilirubin level for liver transaction, say as for example in cholangiocarcinoma, so after stenting or ERCP stenting or PTVD stenting, what should be the minimum bilirubin level before we proceed for liver transaction?
If you ask me or you ask the general guidelines? The two aspects. Can you hear me, Dr. Das? Dr. Das, can you hear me?
We can't hear you.
I can hear you.
There is unstable internet and
Can you hear me now?
We can hear you when we want your opinion.
Yeah, I can hear you now.
I do not believe in cholangiocarcinoma, biliary decompression, portal vein embolization, and then doing the surgery. Because every time I try and do this, when the patient comes back, I find the disease has advanced and it becomes unresectable. I don't know what has been the experience of Dr. Gangli, Dr. Das, Dr. Zaman, and all the other surgeons here. What has been? But every time I've tried to do this, that preoperative decompression, portal vein embolization to augment the volume. So if I get a cholangiocarcinoma person and he has good liver function in the sense that the INR is corrected by giving vitamin K injection and there's adequate Sorry?
We can hear you now.
You can't hear?
I have zero glass skin experience.
So that is my, but obviously if you go by the Japanese experience and other, they will say that you wait, you will put the side that you want to preserve, you put a drainage there, tube there. If volume is less, you do portal vein embolization, wait till the bilirubin is down to 5 and then proceed with resection. So that is the sort of standard teaching.
And you do not, believe that. You go straight away for a surgery.
Yeah. Because every time I've tried to do this, biliary decompression, portal vein embolization, by the time the patient has come back, the disease has invariably advanced. And what we try and do really is that minimize liver resection by reconstructing the right hepatic artery. So as you know, when you do a CLAT screen tumor, if the right hepatic artery is coming from the superior mesenteric artery, then resection is easy because the artery is lying free. Whereas in normal CLAT skin, the artery would lie very, very close. So what we do is we divide the artery proximal and distal and still do a left hepatectomy, so rather than a right hepatectomy. And therefore, we are able to do this without worrying about the bilirubin. But yes, if you were to do a right hepatectomy with a high bilirubin, you will end up with a problem.
Lovely.
What about portal vein thrombosis? Is it a contraindication for a resection?
The side that you want to remove, if that has portal vein thrombosis, not but the side that you want to preserve, that should have good portal flow.
Good evening, sir.
Good evening.
Sir, myself is Dr. H. Das. Sir, hello, sir. While doing a right hepatectomy, sir, can you tell us some tips how to loop the right vein? Sometimes it becomes very difficult to loop there.
Yeah. I'll tell you what you can do. That is a very good question. If you have a TIPS cannula, then that is the best thing to have. If you don't have a TIPS cannula, you can make one very easily yourself. You can take a syringe and attach a little bit of plastic tubing size. Then once you're freed, once you have dissected, created the groove between the right and middle vein, and you've divided the hepatocaval ligament, try not to pass your right angle through it. Try and pass this TIPS cannula with a jet of fluid. And when you see the jet of fluid coming out from the top end, then you can put your right angle and it'll be looped very easily, rather than trying to loop it with the right angle in the beginning, because you may then injure it. But once the stream of fluid through a TIPS cannula, or the cannula that I've said, you can make a TIPS cannula by attaching a little plastic tubing. You inject it forcefully, it opens up that area, and then you can loop it very easily. So then you will not damage the right hepatic vein.
After doing some water dissection, as you have said, sometimes also there is very difficult to push through the right angle.
Then you're in the wrong plane.
Yeah.
Then you can then you, because the right hepatic vein also, what will happen is there's some lot of so you try and expose it quite a bit from the top, because that's easy, that's under vision.
Yeah.
This side it may not be under vision. So then your assistant retracts carefully. There may be one or two small veins to ligate, and after that, you can just stay on top of the cava. You'll actually find a little depression, and then if you push your TIPS cannula, you will find its jet of fluid coming in easily, and it's very easy to loop that. And in fact, it's not my technique. I learned it from the Koreans, and they do this routinely.
Thank you, sir.
Dr. DJ Bora?
Yes.
Can you come in? You have to unmute yourself. You have to unmute yourself.
Hello, sir. Good evening, sir.
Hello.
Yeah, sir. This is Dr. Bora, sir.
Hello, Dr. Bora.
Yeah, sir. Good evening, sir.
Good
It's a
evening.
nice demonstration of Glisonian pedicle approach. So regarding my question is regarding continuation of with the right hepatic vein. Suppose we have injured the right hepatic vein while trying to dissect it, then what do we have to do to get away from it?
If you have injured it, then the best solution, I would say, is first moment you see you cannot injure it, you cannot traumatize it completely. It would be very one would have to be very sort of a novice if you were to injure it completely. So what usually happens is that as you put your right angle, there's a gush of blood coming. And then you panic and you think may have injured it. I suggest at this stage, if you don't have the backup, you don't have a team with you or an anesthetist or blood arranged or whatever, then at this stage, you put a little bit of Surgicel and just get out from theater. Come another day. But if you see the blood and you have and you have all the backup, then what you can do is you can sort of squeeze it with a thumb forceps and try and loop it at that stage. Because once you've looped it, then invariably you'll be able to repair it even if there's a hole. So, but what I would suggest that you do the phrenocaval dissociation completely. That means ligate all the phrenic veins that are going into it. The diaphragm is separated from the right hepatic vein, so that when you're clamping it, your clamp is on the right hepatic vein, not on the diaphragm. Because you try and put the clamp on the diaphragm, it won't work.
Okay, sir. Thank you, sir.
Thank
you. Gunubi?
Before we conclude, I'd like to thank Siddharth bringing Subhas Gupta, God of liver surgery in the world.
Thank you, sir.
Very much.
You. What a pleasure to meet with all my friends.
Yep. Really.
Thank you. Bye. Take care and have a lovely evening. Lovely weekend.
Yeah, thank you, sir.
Bye. Bye.
Thank you.
Before we leave, we would just want to close the session by a few words by our chairman, sir. Bora sir. Bora sir, can you come in, please? Please unmute yourself, Bora sir. Please unmute yourself.
Thank you. Thank you very much. I'm thankful to you for giving me this opportunity to give my remarks on that subject. Dr. Subhas Gupta.
Thank you, sir.
He explained a complex subject in such a way that it becomes as if it is a very simple thing and as if it is a very easy thing. That is the quality of a professor who can make the complex things simple and easy. Thank you, Dr. Subhas Gupta.
Thank you, sir.
He very nicely he very nicely has tell about this control of bleeding in liver resection. This anatomy of liver, it is very much important to know before doing any liver surgery. And he very nicely described about the various devices or how to do the liver resection by use of Kelly or ultrasonic resection or it is harmonic scalpel. And again, he also very nicely elaborate regarding vascular reconstruction. So we have learned many things from him today in case of this liver resection. I again thanks to Dr. Subhas for enlightening us about this things. I also thank the moderator to take part in this event. About questions comes to, and it indicates you make the subject interesting to all. So I thank our Dr. Pan, who has arranged this series of webinar, or by which the most legendary surgeons of India comes to our drawing room and we can interact with him. Thank you. I offer my heartiest thanks to all participants of this webinar. Thank you.
Thank you, sir.
Over to
Thank you, sir.
Bye, everybody. Bye.
Bye.
Thank you so much, sir. Thank you so much, sir.
Bye, Dr. Gangli, Dr. Das, everybody, Dr. Zaman, all bye. Bye.
Okay, sir. Thank you so much.
Thank you.